Hi, I'm Dr. Jess, and I am here with Dr. Lervick. Dr. Lervick is a dentist out of Grandview Center for Dentistry. And so, Dr. Lervick, why don't you introduce yourself and tell us how you got into dentistry and what is your passion with dentistry now?
I'm Bridget Lervick. I'm actually a general dentist in Edina. So my practice is located Grandview Center for Dentistry in Edina. And I made my way into dentistry. My mom was a nurse growing up, so I always knew I wanted to help people. I always knew I was interested in healthcare. And so I landed in dentistry, which has been perfect for me. But one thing that really changed my journey was when I became a mom. My daughter is now 7, and I learned with my daughter that one of the hardest things I ever did in my life was try to feed a baby who was lip and tongue tied. And so that's actually how I learned about lip and tongue ties, was as a nursing mom. Learned nothing about it in dental school. And so went through that experience, and that gave me the realization that this was a huge passion area for me to help moms that were struggling with the same thing overcome the anatomy that was causing so many challenges early on in life when they were just trying to bond with their babies. So my practice is not solely lip and tongue ties, but it is a large part of what we do. We dedicate our Wednesday afternoons, half a day a week, to just seeing moms and babies that have concerns with tethered oral tissues and trying to help them get off to a better start to life.
That's amazing. And you do both tongue and lip and
You
buccal.
buckle. Yep.
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 Amazing. How do you determine whether or not that tongue is more of like an anterior versus posterior, or is it pretty in that anatomical, like you can see it right away type of thing, or how does that
No, there is actually a whole range of what is considered a lip or a tongue tie. So every baby, every person is born with tissue under their lip and tongues to hold together the anatomy. And what really constitutes a lip or a tongue tie is that tissue being too tight and preventing function. And oftentimes we can pick that up initially with inability to either breast or bottle feed, have an efficient latch and milk transfer. I always tell my patients, nobody has died from a tongue tie. So there are certainly times where it is missed and people struggle through. But depending on the level of attachment, we use a grading scale. So for lips, 1 to 3 is how we grade a lip. In my world, I use what's called the Stanford system. So 1 is the most restricted. For tongues, I use what's called the CHIRO system. So 1 to 4 is how we grade tongues, and 1 is the most restricted. So when I'm doing my evaluation to determine anterior or posterior, I'm looking in there to see how restricted is that anatomy, where are the attachments, a functional assessment of kind of how the tissue moves. It's structure and function. And so we take a really detailed intake from our patients to kind of ask questions like, is baby really gassy, really fussy? Is there milk leaking out the sides? Is there a clicking noise? So you might have a baby that has what looks like a grade 1 tongue tie, which is more anterior, really restricted, and they might say no to a lot of the things on that checklist. You might have a baby who the tissue is more posterior. There's not a lot when you look under the tongue. You might think, is there a tongue tie? But they have all these symptoms. And so it's always a marriage of structure and function for me to decide and recommend whether we're recommending moving forward with a procedure or not.
Absolutely. And when you say procedure, do you mean laser, scissors? Could you tell about the process you
Yeah.
guys do in your clinic?
Yes. So in our office, we do use a laser, specifically a CO2 laser, which is the most gentle on the tissue. The actual logistics of it, the science of it, the physics of it are to target water. And so it's really gentle because that's what the tissue is made up of. So it's a really gentle opening of the tissue. Versus the scissors, where there tends to be a little more bleeding. The laser, there's minimal risk of bleeding, swelling, and infection. But I'll always tell families it's still not nothing. There's still going to be a recovery process, usually a few days of soreness and fussiness. But in general, the laser is the best, in my opinion, the best tool for this, especially in the infant population.
And that's honestly what we see in our practice too. Like we obviously don't do the revisions here, but we also see a lot of like the post recovery as well.
Mhm.
And truth be told, we see better recovery with the laser versus the scissors. And
Yeah.
so I'm also with you on that one as
Yeah, and it's hard because it's about kind of the baby's ability to sit there for a procedure. It's hard to work on a baby. And so to get a really good thorough release with a scissors, it can absolutely be done, but oftentimes not without sedation.
Right.
This is a laser procedure in office, which it's usually 5 to 10 seconds per site to get a nice full release that's going to be, something that sets the baby off on a better
Yeah.
path to life.
And so for parents who haven't been in for a consultation at all or are thinking about a treatment, how long typically is the infant away from mom before coming back to mom to nurse and everything?
Yeah, so in our office, we do kind of a full intake. And so we schedule an hour, but the first probably 20 to 30 to 40 minutes of that hour is us doing our assessment with parents in the room, taking photos, talking about what we're seeing. Then we kind of move into talking about here's what you can expect from the procedure. Here's kind of what you would be committing to. And then if we decide that, that day's an appropriate time to move forward, then we actually typically we keep baby in the room with us. We have in our space what we call a comfort room, where best case is usually mom and dad being set up in the comfort room so that mom is ready immediately to either nurse or bottle feed, because that's what's going to provide baby the most comfort post-procedure. Per site, the procedure takes 5 to 10 seconds. So if we're doing lip and tongue, I'll usually tell parents baby's away from you for maybe 5 minutes, because we're making sure baby's comfortable, doing the procedure, giving baby a little break, taking some after photos, and then we bring baby back as soon as we can. Because I as a mom have been in that position before too, where it's just like, it's hard to have your baby need something. And so we're very sensitive to making it the best experience possible.
Okay, good. And then with post revision stretches, how often would you recommend parents doing them? When do you want to see parents back for just a recheck? What does that process look like?
Yeah, so the stretching is kind of one of those stigma things with lip and tongue ties. Everyone hears about the stretches, and I will say they're not fun, but it is absolute key to healing. If you're gonna, go through the laser release, you have to be committed to doing stretches and doing them well so that we get the best results. And for me, I recommend 6 times a day for 3 weeks. So 6 times a day, ideally spaced out every 4 hours. However, I've been a parent, and so my max, let's say baby is sleeping a 6-hour stretch overnight. I'm not opposed to, let's go a little longer, get some sleep. Just then in the morning, we know we might need to do a little deeper stretch, a little longer hold, but arrested parents can be a better parent too. So the overnight is like, we want you doing them, but if you can get a little stretch of sleep, that's helpful. So 6 times a day is what I recommend for 3 weeks. And then in our office, we like to see families back for a 1-week follow-up and a 4-week follow-up. Primarily that 1-week follow-up is just to make sure stretches are going well. I always tell families, nobody walks in here having ever stretched their baby's tongue, and we get that. And so we demonstrate stretches on the front end before procedure, but then we do that 1-week check to just make sure that, if things are reattaching, then I have an opportunity to get in there. I can do a deeper stretch and reset healing. So hopefully we can avoid another procedure, but it also just gives parents that reassurance, because everyone wants to do a good job and get the best result possible. So that's our 1-week check. And then we do a 4-week check, and that's usually kind of our graduation. Doesn't mean baby's done with everything that they need to get a successful result. Sometimes there are other therapies needed. One in particular is suck training. So now that we've given baby new anatomy, some babies get it on their own. They don't need a lot of extra help, but then some babies need a little more it's almost like physical therapy for the tongue, kind of figure out how do we now use this tongue most effectively and start resolving these symptoms of clicking and milk leaking out the sides, because sometimes release alone isn't enough to resolve everything that baby is struggling with. And sometimes it does a really nice job of it. So
Absolutely. So the body work through the revision process is the most important, or not most important, but like also key to make sure that
keeping baby
recovery.
nice and loose, and all of them. So
Absolutely.
I'm not the only one on the team by any means.
And that's what I love about us in general, is just we work with so many different providers around the area, and just like we're always a unit to support these families however best we can, type of thing, which is really incredible. When it comes to revisions for your clinic, do you solely focus on the infants, or what does that age timeline look like before you're going to wait until they're a little bit older, type of thing?
Yeah, so oftentimes there kind of becomes an age where it becomes difficult to treat. And so usually once baby's gotten to like 12 months, until essentially they can follow directions in the dental chair. And so that's different for every kiddo. But if we miss that window when they're younger, oftentimes we are waiting until they're 4, 5, 6, 7, because what happens is in order to do a successful release when they're older, kiddos get teeth. And so you can't really stretch once they have teeth in. And so at that point, we're waiting to do a release until I can actually kind of place sutures under the tongue.
Yeah.
So that's my ideal. If I miss them as an infant, then rather than trying to get mom or dad to, run after a 4-year-old and try to do stretches that they're not going to do,
Yeah.
it's waiting until kiddo can kind of sit, for treatment in a dental chair, which again, every kid's different. I've done a successful release for a 4-year-old by numbing, doing the laser release, and being able to place stitches under the tongue, which means they have to hold it still. But then I've also had 8-year-olds that's a big challenge. We also see adults. So we've got, again, adults that have neck and shoulder tension or other symptoms that are pointing to tongue restriction being something that might be helpful to resolve. So yeah, we do see, I would say, older kids and adults.
Yeah.
So yeah.
Okay. And so with infants, it's primarily like the teamwork is like lactation consultant, craniosacral therapy, speech pathologist, and that type of thing. Older kiddos, is that more oromyofunctional therapist as
Yes.
well as speech therapist too type of thing?
Sometimes speech can come into play. It just depends. So myofunctional therapy is what is really kind of the key. And that is essentially getting the tongue in the right position, making sure we don't have any breathing concerns, breathing through our nose instead of our mouth. And so those are always the goals of that myofunctional therapy, where my role is in the middle of that usually. So oftentimes it's a few sessions with myo, knowing that the tongue tone is there, because then for those kids or adults, I'm doing what's called a functional release, so that I know that we've gained ground, relying on certain measurements. And then yes, oftentimes chiro or body work to kind of make sure that neck and shoulder tension is getting resolved, and any other kind of side effects that might be part of it.
Yeah, absolutely. And so when parents are looking, what are like the most common symptoms for an infant as well as a child as well as an adult that you're looking for with that tongue time, essentially?
Yeah, so infants, the biggest thing is feeding, because that's very noticeable. And so it can be what used to be described as colic, which oftentimes is baby not staying full. They're upset, they're gassy, and that used to be written off as colic. And now we know we might want to screen for a tongue tie if we're seeing a baby that just can't settle. Milk leaking up the sides, pain for mom, that's one of the big ones. And then for baby, I mean, oftentimes it's, babies that take a really long time to nurse, or they might have really short, frequent nursing sessions because they're
Almost
not
like
able to
cluster
transfer.
feeding.
Yes, exactly. So, and that's what I experienced with my daughter, and just that was that and pain. I very much remember that, and it's just like that visceral, like I can still feel that latch where it's like toe curling pain for mom. And so, but it's not always pain for mom. It can look like different things with baby just kind of being off, or like, especially milk leaking out the sides, clicking, gassiness, fussiness, a lot of those types of things for babies. For, usually like the toddler range. Oh, the other thing with babies too is like open mouth posture. So mouth breathing can be a big one. And if that continues into toddlerhood, mouth breathing means the tongue's not in the right spot, which actually stimulates the vagus nerve, which is our rest and digest. And so if we can't get into rest and digest, we're stuck in fight or flight. And so things like sleep can be disturbed. Babies or toddlers might start getting enlarged tonsils. And so now their airway is cut off even more. We're breathing through our mouth, the air is not warmed or filtered. And so it starts to irritate the tonsils, which can further enlarge and cut off airway. So breathing, snoring, sleep disturbances, picky eating.
Ear infections too.
Ear infections, absolutely, because that kind of causes the tongue to not be able to help drain, with the anatomy of kiddos. One of the other things too is picky eating. So kids might look like, oh, I don't like that food, but they may not physically be able to move it around their mouth. So eating looks scary for them. So they choose, I don't like that food. So baby-led weaning is really a good thing to do. So it's not all purees and they're actually trying to use their tongue.
Right.
fast forward to adulthood, and oftentimes we get then kind of forward head posture to try to open up airway. And that might look like a lot of neck and shoulder tension because the head's not meant to be supported out in the front. And so we do see a lot of TMJ issues, headaches, sometimes speech issues for adults that haven't had it treated as well. So yeah,
Do you
there's
see a
whole
lot of
range of symptoms.
sleep apnea in adults as well?
Absolutely. Yeah, it can certainly progress that. The other thing is a dentist, if there's a tongue tie, oftentimes those are my patients that are gaggers. They don't like sensors in their mouth because again, it's like you're putting one more thing in this space that is not large anyway. The tongue isn't really functioning all that well. And so you put one more thing in and it's like, you know, we're smart. You know, again, no one's died from a tongue tie, but we've figured out ways to compensate.
Yeah.
Those compensations aren't always healthy. So,
Absolutely.
and sleep apnea is a big one for sure.
Yeah. With the toddlers that we see that do have this, speaking of gag reflex, they have super strong gag reflex, we're like, just stimulate it as much as you can to almost try to
desensitize it. Yeah.
Try to get that tongue to stimulate it more and everything like that. And we usually have quite a bit of success, which is amazing.
Yeah.
Thank you, Dr. Liver, for being with us here today. And I appreciate you with all of your knowledge. And thank you.
Yeah, happy to share my input. And it's always good to have that perspective from a provider standpoint, but also, again, I've been through it as a parent, so I get the practical aspect of it too.